So I would like to thank Corrado Moretti and George Brunner for inviting me to this very beautiful postgraduate IPOKRaTES course, and I'm honored to speak as a hamburger in a sandwich in between the two stars of neonatal neurology, Donna Ferriero, who, can I say that, is starting from today, is the new director of the Department of Pediatrics at University of California, San Francisco. And Eugenio Mercurio is a worldwide renowned expert in neuromuscular disorder in infants and children. Anyway, here I am. I'm a child neurologist, neonatal neurologist, and neurophysiologist. So what we will talk today, we'll talk today about seizures. What happened to the brain when it has a lot of seizures, status epilepticus, especially in the immature brain. And this afternoon, we will talk about how to classify, how to interpret, how to diagnose newborns with seizures. So this morning is a basic research lecture, and I would like to introduce you to the mechanism of seizure-induced damage in the immature brain. Why we talk about seizures? Seizures are the most common neurological emergency in babies, and they occur most frequently at this time of life than in any other. So neonatal brain, it responds with seizures to several insults that could be hypoxic ischemic encephalopathy, cerebral malformation, infection, transient metabolic disturbances, inborn error of metabolism, vascular disease, stroke. So the reaction of the immature brain to all of these insults is seizure. Why this happen? First of all, why we are interested in mechanism of seizure-induced damage. We start from the clinic, and we try in our translational research to answer questions that comes from the clinics. We answer questions at the bench side. So we know that the earlier the age of onset of seizure, the higher is the likelihood of neurological sequelae. And particularly detrimental for the brain are seizures during the neonatal period. Indeed, has been known for a long time that half of term infants who have seizure are subsequently handicapped, and this increased to almost 90% in preterm infants. However, this is a recent study published by Ronan, and it shows you how about 45% of newborn with seizure are normal in the follow-up. 10% died, and 39% have neurological impairment. So we have this 50% of babies with seizures as a newborn that do bad, and you have 50% of babies who have seizure as a newborn and they do well. This is a very nice paper that has been published by Steve Miller when he was at University of California, San Francisco, and Donna Ferriero and Jim Barkovich. And they studied 90 full-term infants with perinatal asphyxia presented with clinical seizures. They studied them with MRI and MRI spectroscopy, and they found that the severity of seizure was independently associated with increasing lactate in the basal nuclei and intervascular boundary zone. And the damage induced by seizure was not limited only to the structural damage induced by hypoxic ischemia. And actually, what they show is that if you don't have seizure, so they looked at metabolites at peaks in basal nuclei and intervascular boundary zone, and they found that if a baby has no seizure, NAA peak, which is the wider peak in a normal spectra, and it speaks about the integrity of neuron cells. So if there is no seizure, the peak is higher, NAA peak is higher, but if you have seizure, you have an increase of lactate peak. That means cell damage and the decrease of NAA. Same in the intervascular boundary zone. No seizure, NAA is quite wide, and no lactate. But baby with seizure express low NAA and higher lactate peak. So this means that seizures seems to induce a damage directly to the brain. However, we know about benign familial neonatal seizures. This is a rare genetic epilepsy of the newborn. These neonates are healthy until 2 or 3 days of life when seizures begin. And they start and they are brief, but very, very frequent, and babies usually go into status epilepticus. Duration of clusters can be up to 3 days or even longer. However, they have a favorable outcome in regard to seizure, to epilepsy, and they have a normal neurological development. How can this happen? So we know that seizures during the neonatal period are generally associated with adverse neurological outcome. But we also know from clinical that some seizure syndrome in the neonatal period, they have excellent outcome. So it is unclear how much seizure per se contribute to the outcome and how much seizure per se damage the brain. So our question from the clinic, we want to know why is the neonatal brain so prone to seizure? Why the neonatal brain respond with seizure to several insults? Do seizure per se cause damage in the immature brain? And what are the mechanisms of seizure-induced damage in the neonatal brain? Why understanding mechanism is important? You have to know that none of the currently marketed anti-epileptic drug can prevent the development of human epilepsy. They can prevent seizures, but they cannot prevent epilepsy, which is a chronic disease. Understanding the molecular and genetic basis of epilepsy will lead to identification of neuroprotective strategies, of anti-epilepsy strategies in the human brain. And translating discoveries at the molecular level need a validated animal model. Why do we need animal models to do that? Because determining the consequence of seizure, and I show you the paper from Steve Miller, so those are hypoxic ischemic encephalopathic babies, can be difficult because several factors may contribute to outcome. Etiology, age at onset, seizure type, frequency and duration, and the use of anti-epileptic drugs that can be also detrimental to the human brain, to the neonatal brain. In animal studies, this variable can be controlled. Most of the studies on neonatal seizures, and on seizure, are about hippocampus. Why hippocampus? Because hippocampus is gray matter, is most vulnerable to seizure-induced damage, is very known to have a role in certain form of epilepsy in humans, such as mesial temporal lobe epilepsy, and the structural changes caused by seizure are accompanied by deficit in learning and memory. So why is the neonatal brain so prone to seizure? At all age, a seizure happens when there is an imbalance between excitation and inhibition. Excitation is given by glutamate, and inhibition is given by GABA, which is, together with glycine, the most important inhibitory neurotransmitter in the brain, this in the adult brain. In the neonatal brain, GABA-A, NMDA, and AMPA receptors play a developmentally regulated ménage à trois. Donna already shown you these slides, but why it's important for us now is because GABA, which, as I told you, is the most important inhibitory neurotransmitter in the adult brain, act actually as a depolarizing, as an excitatory neurotransmitter in the neonatal brain. And only later in life, he will become inhibitory. So in the newborn brain, the three main ionotropic receptors, GABA-A, AMPA, and NMDA, display a sequential participation to neuronal excitation. So NMDA is working and is depolarizing, GABA-B is still silent, and GABA-A, instead of being depolarizing, hyperpolarizing, as it will become later, so it will become an inhibitory neurotransmitter, is actually depolarizing in the neonatal brain. So there is an imbalance between depolarization and hyperpolarization. So there is an imbalance between excitation and inhibition in favor of excitation. Why the brain needs to have this imbalance? Why this happens in the neonatal brain? At any age, one of the key factors in the human brain's ability to change via neuroplasticity is that neurons form interconnection based on simultaneous firing over a period of time. And the immature brain needs this continuous firing because it needs to develop, and excitation is required for developing. Neurons that fire together wire together. If you do not excite this neuron, if these neurons do not fire so much, they won't be able to connect together and create synapses. But as we said, the pathophysiology of seizures is an imbalance between glutamate and GABA. And in the brain, in the neonatal brain, there is less inhibition than in the adult and more excitation than the adult. So do seizures per se cause brain damage in the immature brain? Several studies showed that the average full-scale IQ of children decrease with the number of years with seizures, with intractable epilepsies. This is a nice study published 10 years ago by Vasconcelos on epilepsy, and this studied 100 patients with intractable epilepsy due to focal brain lesions, and they found that actually age at seizure onset, independently from etiology, was associated with low IQ score. And children with onset of epilepsy before 2 years of age had a full-scale IQ 14 points below that what was seen in patients with onset after 2 years. So the full-scale IQ decrease as a function of duration of epilepsy. So seizures are bad for the immature brain. First of all, the effect of seizure and status epilepticus has been studied in the immature animal. And what did we find? In the hippocampus of the immature animal subjected to status epilepticus, we have neuronal death, so neuronal loss, gliosis, a synaptic reorganization, changes in receptor function, neoneurogenesis, and consequently, those changes at molecular level will induce behavioral deficit and will give spontaneous seizures. So the rat become epileptic. Animal models of mesial temporal lobe epilepsy, as I was telling you, we study hippocampus because there is a similarity in pathology with the animal models of mesial temporal lobe epilepsy and the human hippocampal sclerosis. Both of them give a chronic hyperexcitability, and after a latent period, the rat becomes epileptic. So the rat becomes having spontaneous seizures. We have several animal models of status epilepticus. Partial status epilepticus is induced by chemicals such as kainic acid, pilocarpine, or electrical stimulation, such as perforant path stimulation and kindling. And we can induce generalized status epilepticus by giving fluorothil or pentyletrozole. What happened in the CA3 region, in the hippocampal region, of an adult animal subjected to status epilepticus? You have a cell loss, as you can see here is the CA3 region of the hippocampal region in the adult brain, and you see there is a clear cell loss when compared with control. But as Donna told you, a small brain does not equal a big brain. So what happens when a newborn brain is subjected to status epilepticus? Compared with the adult brain, CA3 region, CA1, CA2, and CA3 region, in the adult brain, you have a huge cell loss, a huge neuronal death, and this doesn't happen in the neonatal brain. So what has been debated in the last 10 years, 15 years, is that it's true. Seizures are most common in the first decade of life and are very, very common in the neonatal period. So the immature brain, because of this imbalance between excitation and inhibition, is more susceptible to seizures compared to an adult brain. However, if we look at the cell loss after status epilepticus in adult animal versus newborn animal, we see that the young animals seem to be more susceptible but also less vulnerable to seizure-induced damage. Epileptogenesis is a long-term process. You have the initial insult, and then after days, to months, to years, you can go to epileptogenesis, which is a chronic rearrangement of synapses and molecular receptor in the brain, and this will lead to spontaneous seizures and increased damage. So we enter the concept of sprouting. Sprouting is a process that happens after acute event, as a long seizure, as repeated seizure, and is due to increased seizure susceptibility, leads to increased seizure susceptibility and to permanent impairment in learning and memory. So this is an hippocampus. This is a CA1, CA2, and CA3 region of the hippocampus in a control rat. And this is a rat that has been subjected to status epilepticus as a newborn. You can see here the cells, the body cells that are marked with thionin staining. And here you have the terminals that are rich of zinc and can be marked with thionin staining. So what happened in the adult brain, you have these two connecting cells in the inner molecular layer of the hippocampus, and you have a mossy cells. These cells are granule cells who are excitatory cells, and this excitation is mediated by the mossy cell. After a status epilepticus or prolonged seizure, the mossy cell die, so we have a cell loss. And so there is this mossy fiber sprouting. These axons are called mossy fibers because they should connect two granule cells through a mossy cell. And this connection between these two cells creates a loop of excitatory, a loop of excitation. So this cell will start to have an increased seizure susceptibility, a continued excitation, and will produce spontaneous seizures. So in the newborn brain, this axonal reorganization, so this sprouting of dentate granule cell mossy fiber into the inner molecular layer of the dentate gyrus will happen even without cell loss. And this will lead to an altered neuronal connectivity, and this will be permanent. So we have acute seizure and chronic epilepsy, and chronic epilepsy is a permanent event. So what are the emerging viewpoints? This is from Cavazos in 2007, published on epilepsy research. What happened to this new connection, to these altered neuronal circuits? They will, so this aberrant connection will give epileptiform discharges spontaneously because they will start to recruit additional lamellae and lamellae in an ongoing process, amplifying the epileptic response and playing a role on establishing the persistent hyperexcitability that characterize epilepsies. So from an acute event, we go to chronic disease, and we want to find something to stop the mechanism here. But to stop the mechanism, we need to know which is this mechanism. So understanding how and when seizure-induced sprouting alters function can provide us with therapeutical opportunity to stop this, to prevent the brain to reorganize from an acute event to a chronic disease. So what I found in the Gregory Holmes lab several years ago, we induced status epilepticus in the immature brain, as Donna told you. P5, P7, P12 in rats correspond to newborn period. And we use lithium pilocarpine model of focal status epilepticus. So we give status epilepticus to these rats. And then we examine the rat as young adult at P55. we studied them on the histological base and also on a neurodevelopmental and psychological base. So what happened to this brain after status epilepticus? When we check this brain as young adult, you have a huge sprouting here in the inner molecular layer of the hippocampus, in the dentate gyrus, as well as in the CA3, CA1, CA2, and CA3 region in the hippocampus. So there is an axonal reorganization that happened, and you can see here very clearly. So you have these fibers that cross the inner molecular layer and take synapses that shouldn't be here with other granule cells. And this is methionine of the control rats, and you see there is no altered connection, no fibers that cross the inner molecular layer, and here you can see clearly TIM-stained fibers that cross the inner molecular layer and take these aberrant connections. Why this is important? What's the neurophysiological correspondence to the rat when the rat is adult? So we test the cognitive function of those rats that were subjected to status epilepticus as a newborn, and they had this sprouting in the brain, so this altered connection. We use water maze testing. The rat is put in a swimming pool in which water is opaque by using powdered milk, and the rat doesn't like to stay in the swimming pool. They want to escape, and there is a hidden platform. Then the rat needs to remember to find it as quicker as possible. So the rats, by doing this, we look at the visual, spatial learning, and memory, which is an important function of the hippocampus, especially in the rats, because rat vision is not very good. So they move going with their hippocampus. And this is a rat that is put in the swimming pool. During 4 days, he needs to remember where is the platform. And the platform is put in one of these 4 quadrants of the tank. So the rats in the beginning will start to find it, and then will find the platform quicker and quicker because he wants to escape as soon as he can. So water maze performance in rats subjected with status epilepticus, lithium pilocarpine status epilepticus, was definitely worse compared with controls. So they learn, but they learn slowly. And when we do the probe, so we take out the platform, so we measure how much time a rat spent in that quadrant where was the platform, because he remembers, oh, well, the platform where it was here, so it has to be here. And actually we see that the experimental rats are not very smart, because they spend a little time in the quadrant where the platform was, and they definitely do not remember why, and do not remember where the platform was. And we found a positive correlation between the thickness of the sprouting, so the thickness of aberrant connection, and the time to reach the platform. So the thicker is the sprouting on the hippocampus on those rats, and the slower are the rats in learning and memory. And when those rats were tested with kindling as young adults to test the threshold to seizures, you can see that the rats subjected with lithium pilocarpine, they have a definitely lower threshold to seizures compared with control rats. So we know that recurrent or prolonged seizure in the developing brain can cause damage even without cell loss, and these will result in cognitive impairment and in a decreased seizure threshold that will remain later in life. Those changes are associated with minimal or no cell loss, mostly fiber sprouting, synaptic reorganization, and decreased neurogenesis. Understanding how this happens, it's important because we will know where we can act to prevent epileptogenesis to take place. So we come back from the bench to the clinic. The bench tells us neonatal seizure can cause both acute effect and long-term sequelae. But the crib, so the clinical side, said us that about 50% of neonates with seizure have a good long-term outcome, and that the etiology is the primary determinant of outcome. Bench says us that recurrent seizures in the immature brain induce synaptic reorganization that correlates well with lower seizure threshold and cognitive impairment later in life. However, we know that newborns with benign familial neonatal seizure, they can have status epilepticus and frequent recurrent seizure, and they have a normal developmental outcome. This is an autosomal dominant epilepsy of the newborn, high penetrance, newborns are well, they go into status, and they have a favorable outcome in regard to seizure and neurological development. This is the first epileptic syndrome for which a gene could be localized. What's the mechanism for this spontaneous seizure in the newborn period? There is a mutation that has been found in KCNQ2 and KCNQ3 gene that are located respectively on chromosome 20 and chromosome 8, and they contribute to the formation of the M current, which is a potassium current that leaves the cell after the depolarization induced by sodium and calcium. So it leaves the cells, and by leaving the cells, the potassium will induce an hyperpolarization of the neuron. So the neuron becomes less excitable. But if the channel, the potassium channel, do not work, the potassium current is reduced, and these lead to neuronal excitability by a mechanism of loss of function and ultimately provoke neonatal seizures. So we found a novel mutation in the S4 region of KCNQ2, and we wanted to study the electrophysiology of this mutation in the cell. So this is the mutant rats, half mutant, half wild type, and wild type only. And you can see that the wild type only mouse has a huge current, and so has a good hyperpolarization of the cell, while the mutant has no current, no potassium current going out from the cells because the channel is closed. And when the M channel, so the potassium channel, is active, this is the axon transfected with the mutation of a human mutation, and you have a depolarization followed by a hyperpolarization that protects the cell from a new excitation. So potassium go out from the cell hyperpolarize. But when the potassium channel, the M current, the potassium current is inactive, you have a continued hyperpolarization, depolarization, no rest of the cell, and you have ultimately seizures. Nanda Singh in the University of Utah wanted to check what happened in the brain of this mouse that are transfected and mutant for KCNQ2 and KCNQ3, same mutation that are found in families with benign familial neonatal seizure. So she transfected this mouse, and she recorded the mutant mice for KCNQ2 and KCNQ3 with long-term recording. They were monitored by video EEG, and they showed to have multiple spontaneous recurrent seizure on a near daily basis. So these mice, they were in status epilepticus for days and days and days. And she was video monitoring them, and she was showing that seizures were continuous, inducing a status epilepticus. And then she did exactly what we did. So she examined the brain, and she said, now what I will find is a huge cell loss, or at least a neuronal reorganization that I can see with my TIM staining. But actually, when she checked with NISL, there is no pycnotic cell between the mouse with seizure and the control. So actually, there is no cell death, no cell loss. And the NEUN, who is a marker for neurons, shows that there is no difference in cell loss, in neuronal death, in the mouse with neonatal seizures, with neonatal status epilepticus, and the mouse with with control mouse. And when she checked with team staining, she didn't found any axonal reorganization, so team staining was completely negative for control, but also for mice that have been subjected, that displayed recurrent seizures and status epilepticus for days and days through the adult life. So these rats do not react the same as the one that I show you. So in conclusion, we need to think about this. Neonatal seizure can cause molecular changes at the synaptic level. And these happen even in the absence of cell loss. However, mouse model based on KCNQ2 and KCNQ3 mutation, they definitely parallel the clinical situation of benign familial neonatal seizure, where a lot of seizures do not produce damage in the immature brain. So what we think is that rare disease may teach us something new about the brain that can be relevant to common diseases that affect so many people. I gave you some answer, but there are still unanswered questions. Are there different mechanisms and different consequences of seizure when seizure happen in a normal brain versus an injured brain? Is there a difference between seizure impact in a brain of a newborn with hypoxic ischemic brain damage and the newborn who has an healthy brain, such as in benign familial neonatal seizure? Are different models of seizure induction responsible for this difference? So spontaneous versus chemical induction, is there any difference? What is exactly the time course of abnormal plasticity after the acute insult of seizures? And finally, does knowing the genetic defects can alter our treatment plan? Thank you very much.
Thank you, Roberta and Donna, for these very beautiful speeches. I suppose that there are many questions.
So that there are precise pathways and precise receptors and signaling. But the problem is all those things are modulated in a clinical environment.
That's the $1,000,000 question, the €1,000,000 question. I think what we need to do is establish specific biomarkers for the different phases of injury so that we have a way of following the process as it occurs. So, for example, preconditioning actually is modulated by hydrogen peroxide, but it's modulated by low levels of hydrogen peroxide. When those levels become too high, we get the reverse. We get cell death. So somehow we need to be able to monitor in the developing brain as it's occurring how much oxidative stress is occurring at that particular point in time and try to react to it. So there are ways of non-invasively measuring certain things. We can use near-infrared spectroscopy, for example, to try to do it. Head ultrasound Doppler can tell us a bit about blood flow. I think those are the ways, and hopefully developing newer techniques such as amplitude integrated EEG, and I'll let Roberta talk about that. But this is obviously complex, otherwise we would have figured it out by now. And I think we're not going to figure it out perfectly, more because every individual responds differently. So not only do we have differences in the response that occur over time, we have the individual's response that may be genetically or environmentally situated.
It's a nice combination to have a stroke expert and a seizure expert at the same day. So I'm always surprised when I hear about neonatal seizures and then outcome that we have done very little in terms of seizures in non-asphyctic babies with focal lesions, and we know that they often have a very good cognitive outcome, even if they all start with seizures on day 2 and 3. I mean, they're not too different from the neonatal benign seizures, but they rarely go into status. Now, if we look at the incidence of cognitive problems in these children, it's very, very, very low. I mean, if they have a focal lesions and don't have asphyxia. So can we say that maybe if the seizures are not too severe, they don't go into status and they occur in the very few days after birth, they are more likely to be benign because of a different mechanism from the seizures occurring later? Do you have any thought on that?
I think that for newborns with stroke, it depends on the extension of the stroke. But basically, I agree with you. And I think that a brain that is not fully injured, like an hypoxic ischemic encephalopathic brain, can react and can respond better to seizure, can repair oxidative stress, seizure-induced oxidative stress, better than a brain that has difficulty already to repair the huge damage that they have. I don't think it's only the question of length of seizures, because benign familial neonatal seizure can go into status, and even children with small strokes can have prolonged seizure in the acute phase. But I think that we focused in the past, if I can say 20 years, a lot on the acute response. Oh, we have a seizure, we need to stop seizure, we have a stroke, we have to focus on that moment of the acute stroke. But as Donna nicely showed us, this is a long story. So probably on the long run, a healthy brain can repair more easily than an injured brain. So I think that we should look at the brain, at the newborns that do well, to see why they do well, and to find the mechanism to repair the ones that don't do well.
I'm still confused by it, because I think that the seizures are telling us something about the quality of the brain damage. For example, we just compiled some data looking at our babies who were treated with hypothermia, who actually had stroke and not classic hypoxic ischemic encephalopathy. When we look at those babies treated with hypothermia who had stroke, they ended up with no seizures. So what that says to me is that the hypothermia is doing something about preventing extension of damage that is initiated by that stroke. So it's more than the stroke that's creating the problems that later turn into cognitive outcome in so few, as you and Danny have nicely shown.
I'm not aware of any study looking specifically at the, I mean, in the same way you did 10 years ago, gosh, a long time ago now, with the children with asphyxia. Are you aware of any study looking specifically at the pattern duration, EEG patterns, duration of neonatal seizures and late cognitive development?
That's what we did. This is actually what we recently published on neurology, and we showed that the more seizures are prolonged, the more damage we have in the MRI. So there is a correlation between seizure duration in hypoxic ischemic babies.
In non-hypoxic ischemic.
No.
Non-hypoxic. No, that's what I said. I'm not aware of any study in non-asphyxic babies.
Do you think there's a difference between clinical seizure and non-clinical seizure?
We will discuss this afternoon. I think that seizure diagnosis is an electroclinical diagnosis, so I'm a neurophysiologist, so don't ask me about clinical seizure. I don't think there is any difference between electrical discharge with and without clinical symptoms.
I think there's a bias in the neurology population that electrographic seizures are perhaps what we should be treating. I don't think we have the answer to that yet, and that's why I use the word bias. But I think the data that we're accumulating now with prolonged video EEG monitoring suggests that electrographic seizures are the seizures to treat.
You've been talking about the excitatory role of GABA receptors in the premature babies, and it's a well-known clinical observation that when you're giving midazolam, especially in a high, as a bolus, so you can see that the babies are developing a convulsion. Do you know, or do you have an idea why is midazolam more than diazepam and others? And can you maybe say something about the role of benzodiazepine as controlling seizure in premature babies?
So I don't think there is any real difference between two benzodiazepine. It's just we are more used to midazolam, and midazolam has a short half-life compared with diazepam. For us, for me, benzodiazepine should be used when you are not sure if this is a seizure or not. Benzodiazepine are like an acute response. You can use midazolam if you see something, you are not sure if it's a seizure, you cannot get, while you are waiting for getting the baby on AEG or a full EEG, but if your baby is seizing, you might want to start a more stable anticonvulsant medication such as phenobarbital or phenytoin. Now, you need to know that we don't have the good drug for treating neonatal seizure in premature and term babies. Midazolam, phenobarbital, and phenytoin, they can cause apoptosis, and this is very well shown. More importantly, phenobarbital and phenytoin are effective in less than a half of seizures, of newborns with seizure, even when you cross them. So we don't have the good medication yet. And I think that's why now there is an ongoing project on neonatal seizure treatment trials to try to find a drug that on a way can prevent new seizures, so can cure seizure, but on the other way will not interact with our neuroprotective strategies, because you don't want to give something that induces cell loss in a baby with hypoxic ischemia treated with hypothermia, so you are counteracting hypothermia, you give phenobarbital or phenytoin or midazolam, you induce cell loss and you are preventing the same cell loss.
I think over the next few years we will see increased use of levetiracetam and topiramate, especially when topiramate becomes available in an intravenous formulation. How many people use levetiracetam, Keppra, in the newborn period? See, I think we're learning about its safety, and like everything in neonatology, we end up using things off-label and until we feel comfortable enough. But there is a pilot study going on right now, pharmacokinetics and safety in term babies with HIE, not preterm, so that's a whole other story. And there's also a study, pharmacokinetic safety study going on for bumetanide, which is the drug that will change chloride transport, which is also something you use in the nursery for a renal disease. So again, drugs that potentially could be very safely used in anti-epileptic. But the preterm, we just don't know.
Just to come back to the biology of some of this again. I mean, I think as neonatologists, we have this great fear of hyperoxia because we think our patients are very sensitive to hyperoxia. And we have a great fear of hypoxia because we think our patients are sensitive to hypoxia. But in terms of the lung, I think, in fact, there are pretty good data that at least in animal models, that the lung is actually probably less sensitive to hyperoxia than the adult lung is. And certainly our babies, I think, will tolerate more hypoxia than the adult will. And so I think that there's sort of a biological, if you like, disconnect. While we're dealing with these babies, hyperoxia is a problem because we use too much oxygen, and hypoxia is a problem because of all the things that happen around labor and delivery. But in fact, the organism per se is probably more resistant. And there's probably a message there if we could figure it out.
I'm less worried about hypoxia alone, but hypoxia is usually accompanied by changes in cerebral blood flow, and that's the concern. So it's ischemia and hypoxia that bothers me. Actually, mild hypoxia is probably good for the brain because it upregulates a whole series of things that I showed you, the hypoxia-inducible factor. There are 40 genes at least that get upregulated in the setting of moderate hypoxia that will actually prevent brain injury. So I'm not as worried about pure hypoxia, but it's rare to see pure hypoxia. Those babies who aren't oxygenating well, usually aren't ventilating well, and they're also having changes in cerebral perfusion.